Hello and welcome to the inaugural session of the CUGH Faculty Development Webinar Series, Teaching Global Health through an Interprofessional Lens. My name is Dr. Jessica Everett, and I'm Executive Director of Child Family Health International, as well as a faculty at UCSF within the Department of Family and Community Medicine and Global Health Sciences. It is my pleasure to be here today, as well as to be coordinating this webinar series. I want to recognize the CUGH Education Committee, as well as the Education Product Subcommittee for making this a reality. The goal of this webinar series is to provide faculty with the ability to understand the basics of global health through different professional lenses. Global health is fundamentally an interprofessional pursuit. However, we're not often comfortable teaching from disciplines that are not our own. So one of the goals of CUGH is to help faculty feel more comfortable collaborating with other disciplines as well as teaching from other disciplines. We have 3 of the 6 webinar series set up. Global Health and Law is happening today. We have Global Health and Anthropology. Dr. Peter Brown will be joining us on December 7th. And Global Health and Engineering by Dr. Shannon Marquez on January 31st. To learn more about these webinars and membership in the Consortium of Universities for Global Health, please visit www.cugh.org. As a CUGH member, I just want to emphasize the importance of this organization, their leadership in bringing together the academic community along with other stakeholders to nurture cross-discipline global health engagement, research, service, and education. In addition, CUGH membership is available for both institutions and individuals, and there's a sliding scale fee structure for those that reside in low and middle income countries. So it really is a wonderful gathering place for sharing ideas, networking, developing curriculum, and other resources. Child Family Health International is a nonprofit leader in global health educational experiences for undergraduate through postgraduate trainees. The website is www.cfhi.org. And our tagline is, let the world change you. We have over 35 global health education programs in 10 countries, and we are honored to be able to partner for this webinar series. In addition, I want to point out a very important publication that was spearheaded by CUGH called Identifying Interprofessional Global Health Competencies for 21st Century Health Professionals. This group, stemming from the CUGH Competency Subcommittee under the leadership of Dr. Linda Wilson, focused on developing levels of proficiency and appropriate competencies for those levels within global health education broadly. It's an open access publication, and I've put the URL there so you can all visit that and include it in your work towards global health education and activities. Today we are honored to have Virginia Routhorn, who's co-director of the University of Maryland Baltimore Center for Global Health Education Initiatives, as well as the managing director of the Law and Healthcare Program at the University of Maryland Carey School of Law. She has many accolades, but on a personal and professional level, she's really an inspiration for many of us who are working within global health. Not only has she worked internationally, but Virginia has really led the initiative to recognize the primacy of local global health, which is so important. Global health, as we know, is a discipline that fundamentally crosses disciplines as well as geographic boundaries. It's an effort to reach health equities through multiple lenses, and today we're going to hear about the important information we need to know about law's contribution to the field of global health. Throughout this webinar series, you're going to gather vocabulary, case studies, principles, and additional resources to be able to integrate this information into your teaching and practice. I want to welcome Virginia, and again, thank you for your contributions today.
Thank you, Jessica, for that nice welcome. And welcome to everyone this afternoon. I'd like to first thank Keith Martin and Karen Lamb and Dalal Najera at CUGH for supporting this wonderful webinar series and all you do to make global health work in the world. So today I'm going to talk about global health law. As I believe most of you are non-lawyers, I hope that you get 2 things out of this webinar. First, a comforting sense that you already understand quite a lot about the institutions and bodies of law that make up global health law. And second, that you understand the critical role of law in advancing global health. Okay, so let's start from the broadest perspective, the definition of global health. What you see is the familiar definition of global health from Copeland et al., that specifically notes the importance of interdisciplinary collaboration. In other words, the lofty goals of global health can only be met through a team-based approach. Lawyers have typically not been considered part of the global health team, but they should be. Lawyers, in their role as advisors, advocates, and litigators, are critical actors who can take a program or initiative and push it through the legislative process, write it into regulations, or use the court system to make sure governments honor their health-related obligations. So, global health is a relatively new field. Traditionally, safeguarding a population's health occurred, and still largely does occur, at the national and state level with a web of laws and regulations governing health services, injury and disease prevention, and health promotion. However, in today's globalized world, it has become increasingly obvious that we need a global body of health law to deal with pathogens that span borders, to deal with products and services that cross borders and impact health, and is an avenue for international collective action to promote access to quality health care for all. So let's use food for children as an example. Medical and public health experts know that good nutrition is critical for children and that there are many competing forces that influence a child's nutritional intake. Therefore, public health experts have worked with public health lawyers to address this issue. So, for example, in Maryland, the General Assembly passed Maryland Education Code Annotated Section 7423 in 2016 to require vending machines in public schools to have and use a timing device to regulate access to machines selling foods of minimal nutritional value. And there's a picture of a vending machine there. Similarly, in Canada, in 2008, the Legislative Assembly of Ontario added subsection 8.1 to the Ontario Education Act to establish policies and guidelines with regard to nutritional standards for foods and beverages and for any ingredient contained in food and beverages provided on school premises. This is public health law in action. But what happens when transnational forces influence childhood nutrition? A national law isn't enough. This is when an international framework is necessary, and in this case, in the case of childhood nutrition, in 1981, the World Health Assembly adopted the International Code of Marketing of Breast Milk Substitutes. This is an international health policy framework to shield breastfeeding from commercial promotion that affects parents, health workers, and healthcare systems. Many professions were involved in this effort, but some critical aspects of it, for instance, drafting regulations, understanding how new laws fit in with existing laws, and political advocacy, is global health law in practice. So what is global health law? What it is not is an organized legal system like U.S. law or Maryland law. It is also not a defined body of law such as contract law or tort law or constitutional law. Why? Because legal systems and bodies of law are usually tied to a governmental entity or rulemaking organization. There is no world government to attach a body of global health law to. Global health law has been defined as the legal norms, processes, and institutions that are designed primarily to attain the highest possible standard of physical and mental health for the world's population. It's also been defined as the law that encompasses international law and policy that directly or indirectly affects global health, including treaties, regulations, global strategies, and expert guidelines. If you think of law as a continuum from development of laws to enactment of laws to implementation to enforcement, you realize that global health law is concerned with all of these. But because there are very few ways to enforce laws at the global level, global health law focuses on the first three, with a primary goal of being norm setting, or creating standards and expectations that are reinforced through education and collaboration rather than enforcement. The body of human rights law is a critical underpinning of global health law. The primary human rights declaration is the Universal Declaration of Human Rights. This was adopted by the UN General Assembly in 1948. It was the first international declaration of fundamental human rights and stated, everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care, and necessary social services. The right to health was further defined in 1966 in Article 12 of the International Covenant on Economic, Social, and Cultural Rights. This article holds that the states parties to the present covenant recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. The above language was very useful in establishing health as a human right, but it did not make clear what countries' obligations were under this right. Therefore, in the year 2000, the United Nations Committee on Economic, Social, and Cultural Rights issued what is known as General Comment 14 to provide more explicit operational language on the freedoms and entitlements included under a right to health. So General Comment 14 made clear that the right to health has three categories of obligations: obligations to respect, obligations to protect, and obligations to fulfill the right to health. These include, and these are just a few examples, preventing discrimination in access or delivery of care, refraining from limitations to contraceptive access or family planning, reducing environmental pollution, restricting coercive or harmful culturally based medical practices, and providing proper guidelines for the accreditation of medical facilities, personnel, and equipment. However, importantly, unlike some human rights that must be implemented immediately, like the right to vote, the right to health is subject to something called progressive realization. This means that at a minimum, states must show that they are making every possible effort within available resources to better protect and promote all rights under the covenant. A human rights-based approach to health provides strategies and solutions to address and rectify inequalities, discriminatory practices, and unjust power relations, which are often at the heart of inequitable health outcomes. The goal of a human rights-based approach is to help, urge, or force political entities to help people enjoy the right to health. One strategy is using the right to health to inform health policy development at the international and national level. Another strategy is litigation. Across multiple countries, domestic litigation was and still is a successful strategy for realizing international treaty obligations for the human right to health, providing an avenue for these issues to be heard in a courtroom. This strategy started with advocates using courts to provide HIV prevention, treatment, and care. However, human rights litigation has expanded to include court cases regarding access to care that should have been provided under a national health plan and access to other drugs. Moving beyond the foundational human rights framework, a central feature of global health law is the negotiation, adoption, and monitoring of normative rules among countries. Institutions are needed to do much of this work, including creating norms, mobilizing resources, guiding multiple stakeholders to work collaboratively, and ensuring accountability for results. The World Health Organization is the most important institution for negotiating international health agreements. The WHO is a global public health organization more than a law-based organization. But as I will describe, the process by which the WHO creates norms and ensures accountability is informed by the law and legal processes. The WHO is an organization of 194 member states and funded by these member states. The WHO has constitutional authority to negotiate and monitor normative instruments, both treaties and soft instruments, such as recommendations. The World Health Assembly is the supreme decision-making body for the World Health Organization. It meets in Geneva in May each year and is attended by delegations from all 194 member states. The WHO has three primary ways of creating laws or norms: through World Health Assembly formal regulations, through WHO action plans, which are then endorsed by the World Health Assembly, and by treaty-making powers. The WHO has little authority to enforce compliance, and thus it really relies on governmental implementation through domestic law and policy. So this is a list of policy frameworks adopted through the World Health Assembly, through World Health Assembly resolutions. The International Code of Marketing of Breast Milk Substitutes in 1981, which I mentioned earlier. The International Health Regulations from 2005, which I will discuss shortly. And the Global Code of Practice on the International Recruitment of Health Personnel from 2010. And the following are action plans and policies that were developed by WHO expert panels that the World Health Assembly has endorsed. I won't read all of them, but for example, they include the worldwide eradication of smallpox and the worldwide eradication of polio. The WHO also has the authority to enact treaties, but has only done so once when it adopted the Framework Convention on Tobacco Control in 2003. The treaty is legally binding on 180 ratifying countries. The purpose of the treaty is to protect present and future generations from the devastating health, social, environmental, and economic consequences of tobacco consumption and exposure to tobacco smoke. The FCTC aims to limit tobacco use by creating universal standards and encouraging domestic lawmaking. To this end, the treaty's provisions include rules that govern the production, sale, distribution, advertisement, and taxation of tobacco. FCTC standards are, however, just minimum requirements, and the signatories are encouraged to be even more stringent in regulating tobacco than the treaty requires them to be. To date, the U.S. has signed but not ratified the treaty and is not a party to the FCTC. In practice, that means the U.S. is obliged to refrain in good faith from acts that would defeat the object and purpose of this treaty. Another international organization that influences health and health policy is the World Trade Organization, or WTO. Trade can affect health in multiple ways. Sometimes the impact is direct and the effect is obvious, like when contaminated food products cross a border. Other times the effects of trade liberalization are more indirect. For example, reducing tariffs may lead to lower prices for medical equipment and health-related products, which is often good, or it can make cigarettes less expensive, which is not so good. Trade policies can also make it hard for governments to adopt public health measures like plain packaging for cigarettes. The Agreement on Trade-Related Aspects of Intellectual Property Rights, or TRIPS, is an international agreement administered by the World Trade Organization. It was agreed upon in 1994 and required many developing countries to begin offering patents on medicines for the first time. Government and civil society reaction to increases in drug prices precipitated a series of events challenging these rules, culminating in the 2001 WTO Doha Declaration on TRIPS and Public Health. The declaration affirmed that patent rules should be interpreted and implemented to protect public health and to promote access to medicines for all. Since Doha, more than 60 low and middle income countries have procured generic versions of patented medicines on a large scale, most prominently in the area of antiretroviral drugs. In the last 20 years, other organizations have been created to promote global health solutions outside of the perceived politicization of multilateral organizations such as the UN and WHO, where member countries can potentially hold up initiatives, create power imbalances between rich and poor countries, or withdraw monetary and political support. Two such organizations are Gavi and the Global Fund. These are public-private partnerships that are designed to be independent and multi-sectoral and bring a new governance structure to global health. They are not legal organizations, but their complex governance and rulemaking structures are quite legal and legislative in nature. Gavi was created in the year 2000 to bring public and private sectors to increase access to vaccines for children living in low-resource countries. Countries that are eligible for Gavi support determine what their immunization needs are, apply for funding, and oversee the implementation of their vaccination programs. Gavi's co-financing policy requires that recipient countries contribute toward the cost of vaccines. You can see the governance structure in this graphic. The Global Fund was created in 2002 to accelerate the end of AIDS, tuberculosis, and malaria as epidemics. It is a financing organization that is a partnership between governments, civil society, the private sector, and people affected by the diseases. The Global Fund raises and invests $4 billion a year to support programs run by local experts in countries and communities. The Secretariat of the Global Fund includes approximately 700 staff members based in Geneva. These organizations create binding financing and reporting obligations that can be enforced in courts and therefore are often considered in the bailiwick of what global health lawyers do. Now I'd like to provide a more concrete example of global health law in action. A recent and powerful example of the role of law in global health came during the West African Ebola crisis. As you likely know, an epidemic of the deadly Ebola virus began in Guinea in 2013 and then spread to Liberia and Sierra Leone and continued for over 2 years, resulting in significant loss of life and social disruption across the region of West Africa. Several areas of global health law were raised by this crisis. In the case of serious public health events that endanger international public health, the WHO can declare a public health emergency of international concern, or FAIC, which triggers powers set forth in the international health regulations that I mentioned before. The IHR is an international legal instrument designed to help the international community prevent and respond to acute public health risks that have the potential to cross borders and threaten people worldwide. The IHR is a continuum of regulations that require countries to develop national preparedness capacities to prevent outbreaks of disease, conduct disease surveillance, report significant outbreaks, and exercise public health powers to limit outbreaks while balancing human rights and international trade. The purpose of declaring a FAIC is to ensure a coordinated international response by recommending measures to be taken by the countries experiencing the outbreak and by other countries to prevent or reduce the international spread of disease and avoid unnecessary interference with international traffic. On August 8, 2014, the WHO Director General Margaret Chan declared the West Africa Ebola crisis a FAIC. The FAIC designation had been used only twice before, for the 2009 H1N1 pandemic and the 2014 resurgence of polio, and only once since, recently this year, for the Zika virus outbreak. Dr. Chan asked countries with active Ebola transmission to declare a national emergency, activate disaster management plans, and establish emergency operation centers. She urged the mobilization of health workers, use of personal protective equipment. She made recommendations regarding treatment and isolation of infected individuals. She asked neighboring countries to conduct rigorous surveillance and convene rapid response teams for contact investigations and case management. She also cautioned the international community against international travel or trade restrictions, except for Ebola cases and contacts. Although the WHO recommended against travel and trade restrictions, many countries impose such restrictions on travel to or from the region. On September 2nd, 2014, Dr. Chan advised against this, saying that travel bans were not justified and that they prevented medical experts from entering the affected areas and that they were marginalizing the affected population and potentially worsening the crisis. UN officials working on the ground also criticized the travel restrictions, saying the solution is not in travel restrictions, but ensuring that effective preventive and curative health measures are put in place. Although the WHO's response to Ebola was criticized by some as too slow, lacking in coordination, and ineffective, the clamoring call for an international response by the WHO indicates a strong acceptance of the authority of the WHO to lead an international health crisis and the value of declaring a FAA. Another legal issue raised by Ebola is that of isolation and quarantine. Isolation separates sick people with a contagious disease from people who are not sick. Quarantine separates and restricts the movement of people who were exposed to a contagious disease to see if they become sick. Isolation and quarantine laws are passed and implemented at the national and state level, but I bring them up because they have a global impact. Healthcare providers made decisions regarding whether they would volunteer in Ebola-affected areas based on how they would be treated upon their return to non-affected countries. In the United States, although the Constitution protects individual liberty, it also grants states the right to limit movement in a health emergency. With the news that several private individuals and healthcare workers had returned to the U.S. with the Ebola virus, the federal government and states took legal measures to clarify how individuals who had come into contact with the virus would be quarantined, usually 21 days for anyone returning from having direct contact with Ebola patients in West Africa. This is a picture of Casey Hickox, the Doctors Without Borders nurse whom New Jersey forced into quarantine after she treated Ebola patients in West Africa. She sued Governor Chris Christie for allegedly imprisoning her against her will because she had, quote, no medical, epidemiological, or legal grounds to hold her. Whether her situation was handled well or poorly, it highlights the importance of public health officials and public health lawyers working together to balance public safety and individual rights. In July 2014, President Obama signed an executive order titled Revised List of Quarantinable Communicable Diseases that amended an executive order passed by George W. Bush in April 2003. The amendment signed by President Obama replaced subsection B of the original executive order and added a section that allows the detention of citizens who display severe acute respiratory syndromes, which are diseases that are associated with fever and signs and symptoms of pneumonia or other respiratory illness, are capable of being transmitted from person to person, and that are either causing or have the potential to cause a pandemic, or upon infection, are highly likely to cause mortality or serious morbidity if not properly controlled. Although Ebola was actually listed on the original executive order signed by Bush back in 2003, Obama's amendment ensured that Americans who merely show signs of respiratory illness could be forcibly detained by medical authorities. I would argue that this power already existed, but this signing of an amendment to an executive order was likely a political act to encourage people to feel that the government had the situation under control. The Ebola virus mercifully waned in 2015, although pockets are still active in West Africa. In addition to its tragic human toll, the pandemic taught us that legal mechanisms need to be in place prior to a pandemic to help facilitate a coordinated and effective response that, to the extent possible, preserve the rights of individuals, populations, governments, and businesses. And on that note, I have put a list of references here that may be helpful, and I hope I've described the basics of global health law to all of you, and I'm happy to respond to any questions.
Thank you, Virginia. This is Jessica Everett. I'm going to bring up some of your questions that you have expressed during Virginia's presentation. Virginia, can you hear me okay?
Yes, fine.
Perfect. So Naduka Ozor from Nigeria has the question, why has the WHO not been enabled to enact other treaties after the 56th treaty adopted in 2003?
That's a great question, and it's not a matter of enabling as much as the political will to develop another treaty. The ability to do so is there, and it's a very complex and political process, and so it's the collective will of the members of the World Health Organization to do that, but the authority is there.
Wonderful. Our next question comes from Disha Shetty. What role does the ICJ, the International Court of Justice, have to play in enforcing rules and norms under the international covenant?
That's a great question, and to date it has not had a role in enforcing health as a human right, although people have spoken about that as a possible avenue to hear cases along those lines. Again, it likely has the authority to do that, and it just has not been used for that purpose, although I agree that that is an avenue that could be quite fruitful to enforce the right to health.
Thanks. For those of us who aren't familiar with that court, can you provide some basic information on where that court is based?
You know, I am not an expert on the court. I appreciate the questions relating to the court, and I think that the best avenue would be to really, for me to study that and provide additional resources, because I just don't have enough expertise to talk about it today.
That's excellent. Thank you. So our next question comes from Michelle Keka. How does the WHO ensure that laws are enforced by each country?
Well, that's the $4 million question. It's quite hard for the WHO itself as an international organization to enforce rules. There's not a strong enforcement mechanism. And that's why I spoke about norm setting. By having the collective action of 194 member countries agreeing to a recommendation or agreeing to a treaty, that creates a norm of action that is very influential, that has proven very influential. In terms of enforcement, what you often see is that the WHO will create recommendations or action plans that ask countries to do things within their own political and government structures that can be enforceable. So for the most part, you see enforcement at the national level through national court systems where people have standing to bring those cases. But on the global level, the WHO really does most of their work through norm setting and recommendations.
Excellent, thank you. And we're crowdsourcing some responses too. Rand Vanderwall points out that the ICJ that we just brought up earlier has no enforcing authority. It's more of an arbitration option for countries. So to the extent that that helps answer that question, I appreciate, and I think Virginia does too, any thoughts. Obviously we have over 200 people on this webinar and a lot of expertise in our midst So do feel free to add to the conversation in that way. Our next question comes from Nilofer Hassanzadeh. Nilo asks, due to the fact that bilateral aid doesn't go through organizations such as WHO, how is the aid regulated? And perhaps we want to just define bilateral aid a little bit more. So I think what Nilofer is referring to is aid that's going through the development agencies from one country to another, and that's termed what we term bilateral. So Virginia, do you have any thoughts on the regulation of bilateral aid?
Yeah, I mean, for the most part, the use of that aid is regulated both by the agency providing the aid and then rules on the ground that relate to use of funds. So you're right, you typically don't see organizations such as the WHO getting involved in regulation or how that funding is used. It's often between the funder and the fundee and the rules in both countries relating to how aid is given and used. So that will tell you that just the diversity of different rules and regulations that are out there, given that there's no central rules or enforcement mechanisms, and that often leaves grantees in a difficult position if they have multiple grants of having to deal with multiple sets of rules that need to be followed for each grant process.
Thank you. And certainly there's much written about the vulnerability that bilateral aid has to differing political agendas and wills, such as we saw in PEPFAR. Second question from Nilofer. The TPP, the Trans-Pacific Partnership, has intellectual property laws patenting medical services such as surgical procedures. How do you think they will affect the capacity building on a global scale? And I ask this because I know, Virginia, you're not a trade expert, so I would like any thoughts on that. If you don't have them, then if anyone else has thoughts, it would be great to take some in the question box as well.
Yeah, I am not an expert in trade, but I agree that it's often these trade laws and trade rules that have the most profound effect on resources for health, and it's such an active area of health law, and one that often takes place sort of outside the typical human rights context. So I'm not familiar with the change in rules that she's discussing, but I agree that the trade is a very active area where public health is impacted greatly.
Excellent. And we have a question from Samantha De Leon, a student that's joining the webinar. What is your experience or recommendations to engage students in interprofessional learning and collaboration, especially medical and law students?
Well, that's actually something that I spend a lot of my day doing, and there is such a lot of opportunity there. I mean, the main barrier is just the siloed professional schools, and if I don't know if this student is a medical student or a law student, but what we do on our campus is try to work at the faculty level, asking faculty in both the law school and the medical school and actually other schools on campus whether they would be willing to bring students from other professions into their project in some small way or a funded way to help be part of research projects. And the way we've seen that is that, for instance, in a project relating to maternal mortality that our university undertook in Malawi, it was a medical research project, but we were able to find funds to bring law students along to study the nursing and midwife practice rules and see how those laws were impacted by changes in policy relating to birthing practices. So it's a long answer. I mean, there's no easy answer, but for a student, I would say that to any extent they can reach out to faculty in other schools and ask if there's any way to become involved in ongoing projects. You often find faculty that are delighted to have that expertise and faculty who embrace a concept of interprofessional global health. So that's one way, but I'd also like to welcome the student to email me directly because I have resources on that issue.
Excellent. Thank you so much. We have another question from a trainee. Poonam Patel asks, first, thanks us for the presentation. I think we're seeing a lot of those comments, so thank you again, Virginia. The question is, quote, I have a question on the career development of global health law. I'm already a graduate in global health at UCSF. Is having a degree in law, global health law, a prerequisite to do work with policy development or strategy solution? If not, what would be the best way to move forward? And what resources or organizations do you recommend people getting engaged in?
Jessica, did you say the student is a law student or has a law degree?
No, I believe a graduate, so probably a master's of science in global health they're pursuing, and they're wondering if a legal degree is required. If it's not required, then what would be other avenues to moving towards the legal policy field?
Well, that's a good question, and one thing you might have noticed in my presentation is that there's sort of a fine line between policy and law, and a lot of people with public health degrees probably listened to this presentation and thought, well, they may be familiar with all these organizations and these human rights treaties and issues, and that's because they aren't solely the bailiwick of lawyers. And so without a law degree, there's a huge amount of opportunity to get involved in all the organizations and policies and areas that I discussed. However, there are some jobs that are specifically legal jobs and require training as a lawyer, especially if they relate to litigation and areas where you are required to be barred as an attorney to engage in the practice. And then being trained as an attorney will be very helpful when dealing with complex sort of regulatory governance issues where an understanding of administrative law and legislation is necessary. So I guess the answer is there's a strong role for policy experts and people trained in the law, and sometimes there's quite an overlap in global health law. So the answer is no, I don't think a law degree is necessary, but it can be very helpful in some of the areas I discussed today.
Thank you, Virginia. And on the flip side of that, we have a licensed attorney, Carrie Waybright, joining us, and she wanted to mention that in addition to the synergies that you already mentioned between medicine and law on campus, she does work at as general counsel at her institution, but then she's been utilizing her understanding and knowledge of immigration law to assist the medical students and faculty with regard to immigration law and enabling patients to access care and residency, et cetera, through that mechanism. So that's another option for some synergy there. Thank you, Carrie.
Yeah, I agree. That goes to what you mentioned before, Jessica, about the sort of local global health, and I think what she's describing is a very clear example of providing lawyering with some global health context in mind.
Great. And then this is a question regarding the World Health Organization. Again, Samantha De Leon asks, have there ever been any proposals by experts or WHO member nations to find ways of pursuing the international enforcement of the very few WHO hard instruments, such as a new body or new functions of existing bodies? So any insights into that, Virginia?
I know that's a constant source of discussion, and every year at the World Health Assembly, it's brought up that there are certain areas within, for instance, alcohol control, that would be ripe for a treaty. And there are many advocacy groups that urge the WHO to adopt additional treaties. I'm not aware of any active efforts at this point, though.
Thank you. Marcia Rawlick is joining us from Trinidad, and she asks, does the WHO manage countries that do not follow WHA formal regulations?
By manage, she probably means, to make an effort to enforce the regulations, and the answer is yes. Countries are monitored, including, of course, the USA, monitored for compliance with rules, and reports are issued that discuss how the countries are compliant with guidelines and rules, and expert assistance and technical advice is offered. It's hard to actually enforce rules and regulations. It's more of a collaborative educational process, but the answer to her question is yes.
Thank you. And I'm going to take a question from David Klain. The question is there any international regulation of medical volunteers? And Virginia, I'd love for you to chime in on this. I do want to mention that there are a variety of efforts at country levels. South Africa has led the way in this area. Kenya recently, the health professionals in Kenya created additional regulations around incoming medical volunteers. In Ecuador is also leading the way in this realm. And then there's many stateside initiatives out of the global north, such as in the U.S., the Forum on Education Abroad, the World Medical Association, the AAMC, a variety of different bodies that are creating guidelines and regulations in this regard, as there is growing concern and visibility to the issues of medical volunteers practicing outside their scope of practice or expertise, and also potentially not appropriate follow-up for patients. Virginia, any legal aspects to short-term medical volunteers or clinical volunteers that you're aware of?
Well, I think you couldn't have answered better. It's an area of great concern, and I'm actually looking at it in some regard myself for incoming volunteers to the U.S., and right now the rules are quite burdensome and complex, and so I'm looking at whether there is any increase in sort of medical malpractice or liability with visitors, and I expect that there won't be, because for most part visitors are supervised and in established programs. So there are no internationally accepted regulations right now, nor soft laws on this in this area. There's just been a massive effort to develop guidelines, as Jessica mentioned, and also to create ethical training for short-term volunteers. But the answer is it hasn't risen to the level of sort of high-level international consideration yet.
The WHO has made some policy statements in this regard, although I don't know that it's been codified with any treaties or other kind of multinational efforts behind it. In addition, as health systems grow with economic and personnel resources, they have more bandwidth to monitor and enforce what people are doing. So in the U.S., we have many stringent regulations, as Virginia alluded to, and in many countries, there's a lot of more pressing direct service issues that take precedence. So certainly from the global north, and now through AfroHealth, which is the reincarnation of MEPI, there's efforts that are also multinational happening on the NGO side. So some more shout outs and thanks to you, Virginia. I just want to recognize that people seem very appreciative of CGH, and we echo that as well. A question from Lanhe Shan. The WHO's Ebola response was mostly advising government and providing information. I wonder, what do you think of WHO's future responsibility on pandemic and epidemics should be?
Well, after the Ebola, there were quite a number of panels hosted by WHO itself and other organizations and universities to review WHO's response to Ebola. So that were very complimentary in some respects, critical in others. But I expect that the process will be much more streamlined and enhanced and faster and more respected for future epidemics. So I think you'll see much more a proactive, speedy response on the part of the WHO, taking into account the criticisms they received from the Ebola crisis.
Thank you. And they did issue a great report on that front. We can try and find that and send out the URL. Jason Rosenfeld has a great question. What impact does the United States' refusal to sign international treaties and agreements have on international norm setting, in your opinion?
Yes, that's quite an area of concern. I mean, the impact that it has is it's makes it harder for the United States to be a leader in some of these areas if they are not, if they have not ratified treaties in related treaties. So it does have an effect on norm setting. It does, I think, domestically, we've proceeded with, for instance, tobacco control laws and have an active lobby and a lot of advocacy in that area. So you don't need to be, a country doesn't need to ratify a treaty or be a signatory to be active in an area. You know, they can just pursue it through their own domestic laws. But I think the way he phrased his question is exactly right. To the extent you have very powerful countries not ratifying or signing normative treaties, it does limit or influence the role of norm setting. So there's no better way to say that there is harm there.
Great, thank you so much. We've had some requests for additional educational resources, so I did send some links to the chat box for CUGH's educational training resources, as well as some of the trainings that were pointed out from some attendees. Mona Haymore has a great question. Currently, Global Health and Law is an elective within the MPH degree curriculum. What are your thoughts on this course, and should it be a required one?
You know, I definitely think it should be required. Absolutely, within public health programs, not just the global health track, but all public health schools should require this, because public health is about implementing programs, but equally as important about advocacy. And by that I mean legislative advocacy and legal advocacy, and a program's only as good as, you know, to the extent that it can be adopted by towns and states and countries. And so learning the the political process, learning how you can use courts to enforce laws is, I think, critical for public health law students, for public health students to understand. So I would suggest that it would be required.
Excellent. And Tamu Davidson points out that there is some specialty MPH programs in public health law, so something to look for if you're pursuing those degrees or interested in them. Another question stems from Brianna Shipley, excuse me. Global health is such an expansive, intricate, interdisciplinary topic. What do you think is needed to standardize global health at the educational level, especially at the graduate level? And Virginia, after you answer, I'm happy to chime in on some of the efforts at the CGH, within CGH, to enable the standardization.
Yes, well, Jessica and I and several others and CUGH itself as an organization has focused very considerably on creating content for global health students that is interdisciplinary. In other words, what should all global health students know, no matter what profession they're in, and then what content is necessary for a specific profession. And as Jessica pointed out at the start of the webinar, we have written an article and that was the goal of that article. But so a lot of efforts are underway. One stumbling block, or the opportunity, is that all professions have requirements that influence their curriculum. In other words, there's only so much wiggle room when you're training students toward an exam or toward licensure. So part of our effort, which Jess will describe a little more, is thinking about how some type of consistent, across-the-board global health set of concepts and theories can be added to an existing curriculum without adding it on around the edges. Jess?
Yeah, excellent. And CUGH has a variety of efforts that through membership you can get involved in, including their competency effort as well as the gathering place for undergraduate and graduate degrees in global health. In addition, there's a lot of efforts to kind of define this trajectory of education. And back to the question around potentially troublesome medical volunteering, I think a secondary effect of the standardization is really to make sure we're being authentic, appropriate, ethical, and thoughtful in the way that we are nurturing certain competencies or activities by learners and faculty alike. And so it serves both the standardization function as well as a rigor function, which is so very important, particularly when you're working in vulnerable populations and where power and privilege are certainly at play. The next question comes from Prince Obina. Virginia, what's your view on ethical considerations on using new drugs during emergency situations like the Ebola case in Africa? So I think he's referring to new drugs that are probably patented and perhaps very expensive or prohibitively expensive. What are some of your thoughts on the legal considerations and ethical considerations of that?
Yeah, that's a great question, and I will answer as a lawyer. And the answer that I have is there have to be guidelines in advance developed, and there are efforts underway, actually, so that if an experimental drug is available, it's clear, it's been agreed upon by nations who will have access to that experimental drug, whether it's healthcare providers and what the criteria will be for access to that medication. Figuring out that in advance will make it much facilitate distribution and create a sense in the affected populations that there is a rhyme and reason and equity to who is getting that medication. And I know efforts are underway, and so that's a perfect question. And I think you'll see that in years coming there'll be a better sense of the hierarchy and criteria for experimental drugs.
Excellent. And Laksam Harihan comes to us with this question, which I think echoes the references that everyone's seeing on their screen. But is there any good or specific resource, book, or website that lists examples of legislation already implemented that directly impacts global health in specific categories? So serving as examples for other laws or policies. You've recommended some excellent resources here, Virginia, and you may or may not have a URL on the tip of your tongue, but I can say that we can send this list of resources and any additional ones that you think of to all the attendees. In addition, Virginia, I'm wondering if there's any conferences or entities that people should think of following up with, in addition to, of course, CUGH's excellent annual conference, which is coming up in April in Washington, D.C.
Well, the premier institute that in the U.S. that handles or works on global health law issues is the O'Neill Institute at Georgetown Law School. And they have programs weekly on many of the topics and more that I talked about. Their website has so many resources. So again, that's the O'Neill Institute at Georgetown Law School. They are just leaders in this field. They have incredible speakers. They're going to play a big part in the upcoming CUGH conference in Washington because they're also located in Washington. So I would use that as a first line for resources.
Excellent. Thank you so much, Virginia, from all of us. I know I'm the only one that gets the privilege to actually have my voice heard, but I'm echoing the gratitude from so many people. We're going to be wrapping up now. I want to remind you that the recording will be sent out, and also make sure you save the date on your calendar. We have Global Health and Anthropology with Dr. Peter Brown on December 7th, same time, same place, and Global Health and Engineering with Dr. Shannon Marquez from Drexel University on January 31st. We look forward to seeing you then, and hopefully you found this to be a useful faculty and training development tool. Take good care.
Thanks, everyone.